Good evening. Respected President, Dr. G.S. Vijayakrishnan, Secretary Dr. Altaf, Faculty Dr. RAJEEV JAYADEVAN, Senior Leaders, colleagues and dear friends. Today, the 4th February is the World Cancer Day. And I'm really proud to state that this is the third program the prestigious AMS chapter of IMA Trivandrum branch is conducting in connection with the Cancer Day. We organized a cyclothon in the morning, and it was a huge success. And later, a cancer screening clinic was conducted in association with the esteemed PRS Kirkinos group. This third program is going to be a great academic session. As we know, there are few cancers that can be actually prevented by human intervention. And we are dealing with one of them, colorectal cancer prevention. And I'm really glad to welcome you all for this fantastic academic session. First of all, let me welcome our dynamic president, Dr. G.S. Vijayakrishnan. He's supporting all our activities. Welcome, Dr. G.S. Vijayakrishnan.
Thank you.
Dr. Altaf, our vibrant secretary of IMA Trivandrum branch is here. I'm really glad to welcome Dr. Altaf.
Thank you, sir.
We are really fortunate to have Dr. RAJEEV JAYADEVAN, one of the most sought after speakers as our faculty. He's a well-known person. He completed his MBBS and MD from CMC Vellore with top rank. And he was awarded MRCP in 1996 and obtained board certification in medicine and gastroenterology from New York Medical College. He's a physician, gastroenterologist, a public educator, a great academician, a researcher, mentor, writer, author, a great speaker, a very good friend, and a nice human being. During the peak of pandemic, he wrote several articles for the doctors, the policymakers, and the general public. And I tell you, Dr. RAJEEV, we owe you a lot. And that was a time the COVID was hitting us hard. The social media was flooded with a lot of misinformation. And you are collecting all the information available, analyzing it, and you are religiously providing the correct information to all of us. It was a fantastic, great job. I'm really glad to welcome you, dear Dr. RAJEEV.
Thank you.
And Dr. Anand Marthanda Pillai, he is the convener of our AMS team. He's an interventional cardiologist. I don't need to welcome him. He'll be handling the discussion part. And I welcome all the senior leaders like Dr. Srijit. And I welcome all the participants. And now I request Dr. G.S. Vijayakrishnan, our president, to say a few words. Over to you, Dr. G.S. Vijayakrishnan.
Thank you, sir. Respected Secretary of IMS Trivandrum, Dr. Altaf, AMS Chairman, Dr. Pradeep Karangur, Convener, Dr. Anand Marthanda, and our Speaker, Dr. RAJEEV. This is the third program. AMS conducted third program. IMA the fourth program. Cancer Day at the Narrative. What programs നമ്മുടെ പബ്ലിക്കിന് വേണ്ടിയാണെങ്കിൽ മറ്റുള്ള NGOs ചേർന്ന് പബ്ലിക്കുമായിട്ട് ബന്ധപ്പെട്ട ഹെൽത്ത് എഡ്യൂക്കേഷൻ ക്യാൻസർ സ്ക്രീനിങ് ആണെങ്കിൽ ഇപ്പോൾ നമുക്ക് നമുക്ക് വേണ്ടി ഒരു കണ്ടിന്യൂ മെഡിക്കൽ എഡ്യൂക്കേഷൻ ആണ് നമുക്ക് AMSന്റെ ചാപ്റ്ററിൽ നമുക്കിന്നിവിടെ ലഭ്യമായിരിക്കുന്നത്. നമുക്കറിയാം ഏറ്റവും നല്ലൊരു സ്പീക്കറെ തന്നെയാണ് നമുക്ക് കിട്ടിയേക്കുന്നത്. പ്രത്യേകിച്ച് വിശേഷണത്തിന്റെ ആവശ്യമില്ല, എല്ലാവർക്കും പരിചയമുള്ളൊരു സ്പീക്കർ തന്നെയാണ്. അപ്പൊ കൂടുതൽ സംസാരിച്ച് ദീർഘിപ്പിക്കുന്നില്ല, നമുക്ക് സ്റ്റേറ്റ് വേ നമ്പർ പ്രോഗ്രാമിലേക്ക് കടക്കാം. വൺസ് അഗൈൻ നമ്മുടെ സ്പീക്കറെയും മറ്റുള്ളവരെയും ഇതിനകത്ത് വെൽക്കം ചെയ്യുകയാണ്. ഞാനിവിടെ നിർത്തുന്നു. താങ്ക് യു വെരി മച്ച്.
Now I welcome Dr. Altaf to say a few words, our secretary.
Thank you, sir. Actually, ഇന്നത്തെ ദിവസം നമ്മുടെ AMS മാത്രം ഇന്നിപ്പം ഇത്രയും പ്രോഗ്രാംസ് ഇന്ന് ഇനി നാളെയുണ്ട് പ്രോഗ്രാം. അത് ഓർഗനൈസ് ചെയ്തതിൽ കാര്യത്തിൽ പ്രദീപ് സാറിന്റെ ഒരു ഇനിഷ്യേറ്റീവും ഡ്രൈവ് നമ്മൾ എന്തായാലും അപ്രീഷിയേറ്റ് ചെയ്യേണ്ടതുണ്ട്. അതോടൊപ്പം തന്നെ ഇതിപ്പോ ഇതിന്റെ ടൈറ്റിൽ ക്യാപ്ഷനിൽ പറയുന്ന പോലെ തന്നെ ഇതൊരു അക്കാഡമിക് എൻറിച്ച്മെന്റ്, അത് കണ്ടിന്യൂസ് ആയിട്ട് ഇത്രയും പ്രോഗ്രാംസ് നടത്താനായിട്ടുള്ള എഫേർട്ടിന് തീർച്ചയായിട്ടും IMA അപ്രീഷിയേറ്റ് ചെയ്യുന്നുണ്ട്. അതുപോലെ എല്ലാ മെമ്പേഴ്സിനും വേണ്ടിയിട്ട് ഞാൻ സാറിന് നന്ദി അറിയിക്കുന്നു. അതോടൊപ്പം തന്നെ ഈ പ്രോഗ്രാംസ് AMSന്റെ പ്രോഗ്രാംസ് മുഴുവൻ നമുക്കത് എല്ലാവരും പരമാവധി യൂസ് ചെയ്യേണ്ടതുണ്ട്. തീർച്ചയായിട്ടും ഈ പ്രോഗ്രാമിന് എല്ലാവിധ ആശംസകളും അർപ്പിക്കുന്നു. താങ്ക് യു.
Now I invite Dr. RAJEEV JAYADEVAN to start the session. Over to you, Dr. RAJEEV.
Okay. Good evening to all. Such a pleasure to be among friends as always, and welcome to all people who are attending this session. Special thanks to Dr. Pradeep for his relentless, meticulous planning. We've had so many phone conversations exactly how the session should go, what arrangements must be done, what is the theme that we must use, what is the tone that we must use, who's in the audience. So a lot of planning has gone into this particular program. Special greetings to Dr. Altaf, Dr. Vijayashan, and so many other friends that I have here. Dr. Anand Martha, Dr. Swapna, there's so many doctors, Dr. Srijit, so many doctors are there. So greetings to all. So first let me, because this is a general talk, let me, whenever I do general talks, it is important to go back to some of the basics. So let me just go over a few basics, and then we will do the presentation after that. Time now is 8:17, so we'll finish by around 8:45. I think that is the idea, and then we will have a few minutes for questions, and those questions can be added in the chat box. Hey, are you able to see my whiteboard?
Yes.
Okay. So just to be complete, let me go through the anatomy of the gastrointestinal tract. There's your stomach, and here's your intestine. That's your small intestine, and then, as we know, small intestine is quite long, and small intestine eventually becomes the large intestine here, and that's the cecum, the appendix. And here is the ascending colon, and then ascending colon turns into your transverse colon here, becomes a descending colon. It makes a turn, and then we have the sigmoid colon, and here's the rectum. And so that's the basic anatomy of the colon that we have here. So just for the completion's sake here, I'm going to add that's rectum here, and then this is the sigmoid colon. This is transverse, and here's the cecum. So we are going to be talking specifically about this area of the body, that is the large intestine. So we are not going to talk about this at all. This is as we know, we have this is the esophagus, stomach, small intestine. We're not going to talk about that at all. So here we have the small intestine, large intestine here, and I've labeled the parts for you. And then I'll take you through some of our favorite histology topics here. Now let's do some histology here. So here is the mucosa. Let's say that's a mucosa. And here's a muscle layer, and here is the peritoneum. So let's just color the muscle layer here. This is muscle. And just to label the parts here, mucosa, muscle. This is serosa. And of course, we know this is the peritoneum. And just for completion's sake, I'm going to draw a few lymph nodes outside here. So these are lymph nodes. So now let's look at what happens inside the colon. So this is the inside and this is the outside. So we're clear on that. So first, let me draw a regular polyp. A polyp actually forms within the wall of the lining. So if the intestine looks like this, so the polyp is actually forming within the wall of the colon. So there is the polyp. So this polyp, it grows with time. Over months to years, it grows. And then some of them get really big. And once they get really big, after about 15 years, 10 or 15 years, they develop into a tumor-like thing here. So you can see over a period of time, if this is time, the polyp is actually growing. Now let's look at what is happening inside the polyp. As the polyp grows larger, we're going to see a little bit of what is called severe dysplasia in the polyp. Now, dysplasia is not cancer. It is just abnormal tissue which can potentially turn into cancer. Now, I've drawn in blue there. As the polyp grows larger, this piece of dysplasia gets larger and parts of it turn into cancer. Now watch what happens. As the polyp grows larger, the cancerous part of the polyp starts growing and starts penetrating like a drill through the mucosa, and then it penetrates the outer layer called the serosa, and then it comes outside. So as I draw the same thing in the larger mass here, which went undetected, the cancer actually grows and burrows through the wall of the colon or the rectum, and it eventually involves these lymph nodes. So these are lymph nodes that are involved, and then it can also grow, it can also metastasize. Now, I don't have the space to draw the liver and lungs, but you know what I mean from that. Now, what is important here is what is called the timeline. As I drew here, this is called the timeline. The good thing about this, if there is such a thing, is that if we can take care of this without surgery, we can take care of this without surgery, and this one, if we catch it before it, let's say, before it grows into the wall, we can take care of that. Otherwise, if this is going to need surgery. So that is where things get a little complicated. Now, why would you want to do surgery for something that you can remove without surgery? So this is where surgery comes in. And we know that once it spreads to the lymph nodes here, we're going to need surgery plus chemo. So now, if we look from the left on the timeline, the leftmost lesion, we can remove using just the colonoscope or the sigmoidoscope. I'm talking about this one. This one. This can be removed with a colonoscope. This can be removed with the colonoscope. This can be removed with a colonoscope or something maybe a little bit more severe. Some of these lesions may require surgery. But the moment it goes past the bowel wall, that is when things get complicated and the survival actually comes down after that. So that's a basic premise of the anatomy and the progression of colon cancer. So now I'm going to take you through my PowerPoint presentation. Now, I hope you can see this. Are you able to see the slide now?
Yes, yes.
Yes, okay, here we go. I'll also turn my video on, so I guess you can see me as well when I speak. So I'm going to take you through some practice-changing updates. So let's just look at the scenario. Here's a patient that is sitting in front of one of us as doctors, asking us this question. Doctor, how can I protect myself from bowel cancer? Many doctors have the habit of asking these questions. Say, do you even have any symptoms? Are you seeing blood when you move your bowels? Do you have any family history of bowel cancer? And are you a vegetarian? So patient says no to all these. Doctor, I don't have any symptoms. I just read about bowel cancer. I just thought I'll pay you a visit. I don't have a family history. I'm a vegetarian and I have no symptoms. So that most doctors actually will say, don't worry, which is true. There's no need to worry. Worry is a subjective term. But the question is, are we scientific in giving them this advice, saying, okay, since you don't eat meat, you're not going to get cancer? That's false. You cut out fat and oils in your diet, you know what? That's okay. But that's not going to stop you from getting cancer. You must exercise. Exercise will cut your cancer risk. True to some extent. But you know what? Cancer is very common even among people who exercise. So this is not to discourage exercise, but don't be under the illusion that just because you exercise, you're going to be free from cancer. And we also tell them avoid junk food because junk food and insecticides and they cause cancer. There's no evidence that insecticides are causing cancer. We hear all these allegations, especially on social media, saying it's because of insecticides sprayed on vegetables that we're getting cancer. There's no such evidence, which is why I said in this forum, Academy of Medical Specialties from the IMA, IMA stands for science, and we must follow science, not social media talk. Science is about hard evidence and indisputable facts. So here I'm going to give you some indisputable facts. Let's be very specific. The correct answer is if this patient wants to reduce her or his colon cancer risk at around the age of 40 to 50, the correct answer around the world is get a screening colonoscopy. That's the answer to the question. There is no role in asking this patient to stop eating meat, becoming a vegetarian, buying more fruit, which can be quite expensive actually. Especially after the budget, everybody has increased the prices. If you noticed yesterday, adding salads in your diet. It may look pretty on a photograph and on Facebook, but adding salads is not going to take the cancer risk away from you. So some of these are, I know it sounds a little provocative, but actually some of us have been giving out all the wrong advice to people. And people are diligently following this advice, not knowing that it's actually doing very little to reduce the cancer risk. So what is it that a person can really do to reduce their cancer risk? I'll take you through that. First thing, stop smoking, or at least even better, don't start. Number two, doctors are not here to give convenient advice. Convenience advice. We're not here to become the patient's best friend. Give them the right advice. Stop alcohol. Yes, you heard me. No moderation. Stop alcohol. If you want to cut your cancer risk, stop alcohol. Or even better, don't start. From my article in 2017, I wrote this, that alcohol is carcinogenic, even in the smallest amounts. 2 months ago, the World Health Organization came out with an announcement. That is, all the top brass of World Health Organization put a publication out. I think it was in Lancet. They said, even in the smallest doses, alcohol is carcinogenic. Yes, that's true. Multiple cancers, I'm not going to go into that, including bowel cancer. So if you really want to cut your cancer risk, stop smoking, don't start. Stop alcohol, don't start. It's good to increase fiber in our diet, but fiber is, I repeat, will not stop you from getting colon cancer. It will not. It may, if you take a very, very large number of people, comparing people who've eaten a lot of fiber and people who are eating zero fiber, yes, there may be a marginal difference, but for the person sitting in front of you, it makes no difference. So that's the difference I'm trying to make here. You can look at all these published studies and say the hazard ratio is 0.98 with a confidence interval of 0.83 to 0.99. It looks impressive on paper, but for the patient sitting in front of you, it makes no difference at all. That patient is seeing us to reduce the cancer risk. And that's why I gave you the summary of colon cancer in the beginning by drawing those pictures. So this is always a question that we must ask, not just for colon cancer, but whatever problem the patient comes up, what advice are we giving? Are we giving them quality advice? Have we looked at the quality and the science background of our advice? Or are we just dishing out advice that we are hearing other people give? So that is where I think programs like this will help. Very few cancers are truly preventable. I know it sounds pretty discouraging. That's true. Very few cancers are truly preventable. We are good at detecting cancers, but detection is not the same as prevention. Many people, including doctors, confuse the two. Prevention is stopping cancer before it starts. Detection is picking up cancer at a sufficiently early stage, so the staging is more favorable for survival. So let's take the few preventable cancers. I will say the number one preventable cancer is and always was cervical cancer among women. Yes. You send a patient for pap smears starting at adult age. Yes. Pap smear will reduce the risk of cervical cancer in their lifetime. Also screening for human papillomavirus. Yes. And now we have human papillomavirus vaccination available for children before they become sexually active. That's when they get the HPV infection. And HPV infection, human papillomavirus, causes cervical cancer. So if we can vaccinate a child against this, it's a vaccine preventable virus. Fortunately, it does stop them from getting cervical cancer. Now that applies to both boys and girls, because if the human papillomavirus transmits between people, so it can transmit from male to female. So men and women, or boys and girls, are eligible for HPV vaccination. That's a top preventable cancer. Important fact. Second most important is, again, my area, liver cancer. I know liver cancer can come from many causes, but hundreds of thousands of people get liver cancer from hepatitis B, which is an eminently vaccine preventable disease. I know the Indian vaccination program has included hepatitis B vaccine, but historically, hepatitis B vaccination is cancer preventing, because at least the cancers that come from hepatitis B, we can prevent with a simple vaccination. It's 100% effective, close to 100% effective vaccination for a lifetime. It's one of the finest vaccines ever made. Then we have colorectal cancer, which is preventable by screening, colonoscopy or sigmoidoscopy, or for the minimum, we can send a patient for a fecal occult blood testing, which is not very reliable, but if the fecal occult blood turns positive, then the patient will again have to come for a sigmoidoscopy or preferably a colonoscopy. So it goes in that direction. So these are interventions that as doctors we can make to reduce our patients' future cancer risk. So again, as I mentioned, it's detection before whatever it is turns into cancer. So just for our revision here, the diagram that I wrote, I'm showing you a picture here. Sigmoidoscopy doesn't go all the way, and colonoscopy goes all the way. So it's pretty self-explanatory. It is done as outpatient procedure. And the previous night, they go through a bowel clean out. They take a solution to and the whole thing is cleaned out. The colon becomes so clean, it's as clean as a mouth by the time the camera goes in. And even the smallest lesions can be seen using the camera. And now we have high resolution cameras that can pick up even the smallest cancers and remove them on the spot. That's the best part. It's not just looking, but treating as well. By contrast, physical examination, chest X-ray, mammogram, blood test, all of that will only help detect cancer, and they don't prevent cancer. And here's where many of us get it wrong again. We ask for family history just because we are trained to do it in medical college. You know, we get bonus points if we ask for family history, and we may get a distinction in the medicine orders. But really, you know what? The vast majority of colon cancers that I've seen in my 30 years of experience, most of them have no family history. And if they have family history, it's because they get referred to us. Yes, the vast majority, there's a referral bias there, if you know what I'm talking about. So most colorectal cancers that are seen in practice are sporadic. They don't have a family history. So just because the patient says, no, nobody in my family has colon cancer, that is flawed for two reasons. One, how do you know any of them had colon cancer? Because if they haven't been checked, chances are they won't know that they had colon cancer. And secondly, it's uncommon for, if you take all the colon cancers diagnosed in the world, only about 5% have a family history. And if you remember nothing at all from this talk ever, please remember this. Being vegetarian does not stop someone from getting colon cancer. This is probably the biggest myth that is circulating in India at this point. People seem to have the mistaken idea that if you eat vegetables and fruits, you won't get cancer. That's completely wrong. Now, I'll take you through a couple of studies. I know we don't have a lot of time here. So this is an International Journal of Cancer that looked at red meat intake. That, you know, always we get a feeling that, you know, if you eat red meat, it turns to the cancer. No, it doesn't work like that. In fact, if you look at all the studies that were done, huge, humongous studies that are done, half the studies show no relation between red meat and cancer. I'm not asking people to eat more red meat. I'm saying it is not as bad as you think it is. Half the studies show no relation at all. And then there is the other half shows a tiny, very, very tiny fraction, which is only evident when you look at very large numbers of people, which is why I said that advice is practically of no use to the patient sitting in front of you, that picture that I showed you. And here's the Lancet Oncology report. It is a working group that concluded that there's limited evidence for carcinogenicity of red meat. Yes, it's a group 2A carcinogen, which is the same as diesel fumes. You know, if you stand on the road, you're inhaling a group 2A carcinogen. Now, how many people get cancer from diesel fumes? You ask me. I don't know. I don't know if anyone gets cancer from diesel fumes that I know of. So in other words, red meat is classified as a group 2A carcinogen, but the big but here is processed meat, which is basically smoked meats, sausage, bacon, all that sort of thing. Yes, they are classified equal to cigarette smoke in terms of causing cancer. So I want to make the distinction here. Regular red meat is just a group 2A carcinogen. Okay. So there are two kinds of colonoscopy. If the patient says, look, doctor, I'm having blood when I move my bowels, yes, definitely they need a diagnostic procedure, because you're trying to find out what is the cause of the symptoms, not to prevent cancer there. You're trying to find out the cause of the patient's symptoms. So that's called a diagnostic colonoscopy. And screening colonoscopy, again, for the record, is done on people before symptoms appear. And there's a difference between individual health and public health. For example, let me ask you a simple question. Okay, let's screen everybody for brain cancer. Would anyone endorse doing CT scans on everyone of the brain to screen for brain tumors? I wouldn't do that. Why? Basic epidemiology. I'll explain what it is. There's something called the World Health Organization criteria for cancer screening. To screen for a disease, certain criteria have to go in. Basically, it's common sense, but WHO has put it out the criteria. One, the target disease should be serious and common. So colon cancer falls into that. Effective treatment should be available. You don't screen for something that you can't treat. You can't just do a test on a patient and say, congratulations, I found this disease for you, for which I have no cure to offer. You may go home. Now, that is not screening. You don't subject people to screening if you don't have anything to offer. Number three, the procedures that we use for screening must be acceptable, safe, and relatively inexpensive. Yes, the patient must be able to afford it. So, for example, colonoscopy, look at the cost of colonoscopy. Yeah, I know cost varies in India. It can vary if you compare. I've worked for 10 years in the US. If you look at the rates, compare the rates of the US and India, on average, it's about 50 times less expensive in India, sometimes even 500 times less costly to be performed in India. Of course, again, it depends on the setting, the practice, and so on. So I'm not going to get into that, but it's substantially cheaper than it is in the United States. Colon cancer screening is standard of care in all developed nations. It is not just in the US, in Europe, in all developed nations. And screening, unfortunately, is still not done much in India. And while we are on screening, I'd like you to go through two types of screening. One is opportunistic screening and organized screening. Now, organized screening is initiated by the system, like the United States. People who are the age of 45, they undergo what is called a screening colonoscopy, regardless of their symptoms. That's they screen the whole population because they have the resource to do it. India does not have such unlimited resource. So in India, what we can practice is what's called opportunistic screening, which is the picture that I showed you in the beginning. Here's a patient who's interested in reducing the cancer risk. Young woman, say 45, comes to you, or 50 years old comes to you and says, look, I want to reduce my cancer risk. There are certain things that we can offer this individual at a very, very reasonable cost. And I will also add that, unfortunately, I've seen in some hospitals in India, needless tests being done, expensive and needless tests being done in the name of screening. Now, I'm not going to name those tests. For example, a treadmill test. It is not a screening test. Treadmill test, it does not have a good accuracy record in picking up heart disease. But you see the number of treadmill tests that are being done in hospitals across India. It's got a terrible positive predictive value. Positive predictive value, it varies depending on the prevalence. Now, if the patient falls into a high-risk category or has symptoms compatible with ischemic heart disease, or has a family history, or is in the right age group, yes, a positive treadmill is a lot more predictive than for a 25-year-old who's got absolutely no symptoms. That 25-year-old might turn out to have a false positive treadmill test. So I'm not going to go into that. I'll refer you to my own article on the accuracy of lab tests. You can Google RAJEEV JAYADEVAN, which is my name, and lab tests, and it'll take you through a very, very detailed article where I've explained the basic statistics in plain English on that. So choosing the right test is important. And also, I do not endorse subjecting patients to needless investigations in the name of screening. Unfortunately, that's being done. In America, they say start at age 45. American Cancer Society says that. The modalities, as I mentioned, are on screen there, and then there are some other ones as well. The timeline of screening, as I mentioned here, the red arrow, by the time you pick up the cancer, the survival rate may not be as good as with the yellow arrow there, where you do a simple sigmoidoscopy, remove the polyp, and you basically prevent the cancer from happening completely. So the double advantage of a screening colonoscopy is that you detect and remove polyps. There is the precancerous lesion, which is not cancer. And secondly, if, God forbid, the patient already has silent cancer, you can pick it up at an earlier stage than waiting for it to produce symptoms. So those are the two advantages of screening colonoscopy. Are these effective? Yes. There is a 77% reduction in the incidence of colorectal cancer, and there's a 53% reduction in deaths as a result of screening programs. So here's the declining colon cancer incidence. I'll take you very quickly through the Indian scenario. Unfortunately, the trends we are seeing in India, allowing for a little bit of ascertainment bias, is that the average age of diagnosis of colorectal cancer is below the age of 50. Now, these are series that are published from different parts of India: Cochin, Vellore, Raipur, Kolkata, and Assam. All of them show the percentages of young colorectal cancer series in their own series. Now, my dear friends, Dr. Sunil Mathai and Dr. Binoy Sebastian, all gastroenterologists who are very, very close friends. So they're a nice bunch of people. We get along very well. Now, they have shared their data. They've said that 17% of the colon cancers they saw in one series were less than 50. And here is Prakash Zakaria, a brilliant gastroenterologist, again, good friend of mine, who shared his series. He said 15% of his series was less than 50 in India. So the young patient with colorectal cancer, the question is, when did the polyp first appear? And if the polyp was picked up at 47, when should screening be done? Because a polyp takes time to grow, right? So if you screen only at age 50, many of our patients might miss the bus. So when to screen? 35, 40, 45? These are questions that must be debated in scientific forums. This is a study from Dr. Professor Verghese Thomas and co. The first study to be done in India on polyps. And this is my own study from India that looked at the age where polyps appear. So I'll take you through my graphs. I found that around the age of 40, you start seeing adenomas in India. So adenomas are not cancers, but they're pre-cancer, which basically means they have the potential to grow into cancer. So here is the distribution of cancers, right colon about one out of 3, and about half the colon cancers can be reached with the sigmoidoscope. So to summarize, I'll say this, it's the cost per capita. One must look at opportunistic screening, organized screening in India. You can't screen everybody in India. That's a fact. We don't have the resources, as I mentioned. We don't have fully controlled studies. We give some quality variation. The safety of tests have not been tested in the field. The expertise can vary. The true incidence of colorectal cancer is yet to be determined in our country. And this is my own video. This is a Facebook Live that I did a few years ago to show that colonoscopy this is me undergoing colonoscopy by my colleagues, Dr. Joby Augustin and Dr. Jafir Hassan, with their permission. So I'm actually typing this when the colonoscopy is going on. I just want to show that it can be done safely and comfortably in the right setting. So this is just like they say, if you don't recommend something to your patients that you yourself are not willing to undergo. So this is my attempt to show that I'm willing to undergo this test. I know it's important. I did this when I think I was, maybe mid-40s or something like that. Okay. So in India, we have some barriers between awareness and action. There's prejudice. There's denial. There's plenty of denial in India saying Indians are exceptional. We don't get cancers. We don't get all sorts of diseases. That's really mostly an error of the lack of resources. We don't have all the resources to do the comprehensive databases that developed nations have created. So there are large gaps in our screening and surveillance programs. So we can't really have a comprehensive database yet. So there's a lot of denial there. Just because you can't find it, that doesn't mean it is not there. Some of the statistics are outdated when these testing modalities were not available. Some of the published data on colorectal cancer were done before colonoscopy was widely available. So how reliable will that be? Then there's peer behavior. You copy what your friend or your colleagues do. So if they're doing the wrong thing, you may copy the wrong thing. So then, as I mentioned, every country has this. We also have the Indians a different mindset. When COVID came in, many people believe it will not come to India because we are different. No, that's not true. So many diseases are apparently seen less simply because we are not testing enough. I wrote the Sambar effect, but there's a popular myth that goes around that Sambar prevents colorectal cancer. It's a hoax. It's got nothing to do with colorectal cancer. It's just a simple study on lab mice that got exaggerated out of proportion. In fact, one of my articles is going to come out tomorrow on why that is a myth. All right. So to conclude, colorectal cancer, the incidence is rising in India, mainly because our healthcare sector is vastly more developed now. There's more technology, more screening, more diagnostic tests available. Our longevity is coming up. In Kerala, the life expectancy is almost the same as that in the United States. As people live longer, more diseases get picked up. And you don't really want those diseases if you can prevent them. The second is waiting for symptoms is the wrong strategy. Yes, if somebody comes to you with symptoms, yes, you send them for certain tests. But here, this session is about preventing. Preventing has nothing to do with symptoms. Family history, as I mentioned, is absent in 90%. Young onset colorectal cancer, unfortunately, is a growing problem, not only in India, all over the world. The fastest rising age group of colorectal cancer, unfortunately, is adults under the age of 60. And it's a little bit artifactual because over the age of 60, as the cohorts get older and they're all screened, their mortality is coming down, whereas the younger people are not being screened, so their risk is actually going up. That's one of the potential reasons. Then organize. You can't screen the whole population in India, as I mentioned, but you can do opportunistic screening for people who have the aptitude and the resource to undergo screening tests. And awareness must improve not only among the public, but also among the doctors. So I'll stop here.
Thank you. Thank you, Dr. RAJEEV JAYADEVAN, for that very illustrative talk. The forum is open for discussion. If you have any questions, please feel free to put them in the chat box and we will take them one by one. In the meantime, I'll start with a couple of questions. I know you may not have black and white answers to some of these, but how much would you say that colon cancer is a lifestyle cancer as opposed to predominantly genetically mediated one?
Yeah, it's a very good question, Dr. Anand, that you raised. Colon cancer is caused by accumulating mutations. It's not a lifestyle disease. Unfortunately, if you really, I paint also. If I paint a picture on the risk factors, the certain things like red meat and smoking and all that are blown out of proportion, whereas other things which are harder to understand, like mutations, are underrepresented. Actually, what happens is in that polyp cancer sequence, as the polyp starts as a size of, let's say, a peppercorn, or the size of a peanut, it starts accumulating mutations over time. And why they accumulate, there are basically three sets of mutations that are there. One is called the gatekeeper mutation. You all heard of the APC gene, right? The adenomatous polyposis coli, APC gene, that's called the gatekeeper gene. And the second is called the oncogenes, the KRAS oncogenes, which basically get the cell stuck in the permanently multiplying mode. And then there are other genes that make the cancers more likely to happen. So when these sequential mutations happen over a period of time, that is when colon cancers come. And unfortunately, we can't really pinpoint a particular lifestyle factor into these. Now, there are contributory factors, as I mentioned. Heavy use of alcohol, heavy smokers, yes, definitely that's a risk factor. And people with a family history, very high risk of these mutations because they're already carrying it's like they're starting at that level. The mutations are already there. So it's much, much easier for new mutations to get piled on, which is why anyone with a family history of colorectal cancer, you got to put them on a screening program, even if they don't have any symptoms. So that's a message I have for you. Changing your lifestyle, it's all good. It's not going to make a difference in real life.
Thank you.
For colorectal cancer, right? Colorectal cancer.
Right. Is the prevalence of colorectal cancer in India similar to or comparable to Western world to the extent that you would suggest that an equally aggressive screening strategy should be adopted?
Yeah, which is why I said opportunistic and it can be otherwise for population screening. Population screening cannot be done for the reasons I mentioned earlier. For opportunistic screening, you never know what the colon of the person sitting in front of you looks like, which is why our commitment to the person and our commitment to society should be channeled through different thought processes. When we talk about population screening, yes, we say it is not feasible for the reasons I mentioned. But for the person in front of us, the only way we as a doctor can reduce their lifetime risk, that individual lifetime risk, is through screening. And in terms of how common it is, the published prevalence rates, published incidence rates of colorectal cancer among people of Indian origin, where these facilities are available, is 60% of the West. But that factors into consideration the reluctance of the Indian population to approach the doctor for these tests. Remember, the doctor can only pick up if you take a group of Indians living in, let's say, a foreign country like Germany, unless these people go to the doctor is going to find it. So you got to factor in both these factors. So Western data among people of Indian origin have shown 60%. So in reality, if we take the adjustment, I'll say somewhere around 80% of that of West. It's not like it's so rare here that we don't look for it. I hope that answers your question.
Thank you. Can you comment on CT virtual colonoscopy as a screening tool for colon cancer?
Okay, for our audience, virtual colonoscopy basically means without putting a camera into the body to image the colon. Now, that's cumbersome because you got to put a CT, you got to put them through a bowel clean out, and then they have to get a CT scan which involves radiation. And if it shows an abnormality, you got to bring them back for a full colonoscopy after another bowel clean out. That's a double expense and double trouble for the patient. So CT colography, I've rarely done them for individuals in whom, say, for example, a colonoscopy is not feasible. For example, they may have an abnormal bowel anatomy from previous surgery for something else. So it has a small role, but it is expensive and also involves radiation, which I'm not sure we can subject our population to extra risk.
But in terms of a screening modality, is it sensitive enough to pick up polyps, particularly?
Yeah, good question. That's a good question. Can CT colography? Yes, in very good pair of hands, depending on how good the clean out is, how good the machine is, and how good the reading system is. It's almost as good as colonoscopy. But that being said, the section that I did not show you because we don't have a lot of time there, the quality of colonoscopy also is a big topic in itself to discuss, because not all colonoscopies are the same. How well trained is a colonoscopist? How good is the preparation? How good is the equipment? And how long does a doctor actually spend looking behind each fold? So there are and how good is the experience? What is the polyp detection rate? And so there are so many variables into the technical side of it. But I'll say CT colography and colonoscopy, when done well, are almost equally sensitive. But as I said, the tiniest or the flat lesions, you will not pick it up. Say, for example, there are carpet-like polyps which grow like a doormat or stuck like a doormat on the wall. You will miss it wholesale on a CT colography. It is good for a polyp that is hanging like a mango or a fruit from the wall. Yes, the CT colography can pick it up, but the dangerous ones are the flat ones that grow horizontally. CT will not pick it up.
I'll take some questions from the audience which have been typed in. Basically, can you recommend a regimen at what age you should start screening? If it is initial screening is negative, when it should be repeated. If you find a polyp and it is resected, when it should be repeated.
All excellent question. So I'll say this, as I said, in the US, it's 45, age is 45. I don't see any harm in doing that in India, especially we know I showed you the series of young colorectal cancer, which is why we must detach ourselves from population statistics to individual statistics. There's no harm in recommending a screening procedure as if you're convinced that it can be comfortably and safely done. You've got expertise and the resource to do it. So there are some conditions for that. So someone who's approaching middle age, it's perfectly okay to recommend that. And if it is clear, and if the patient has no risk factors, there is no need to repeat it. Yes, there's no need to repeat it. Or you can put them on a 10-yearly program, because 10 years is a sufficiently wide gap where in between, if a polyp starts growing, you can't pick it up. But you must also remember the miss rate. There's something called the miss rate of colonoscopy. How often do we miss a polyp? So again, allowing for some miss rate, you put them on a 10-year regimen, you can pick it up. Either you can pick up a polyp, or God forbid, if a cancer was missed, you can pick it up. You can still pick it up at in your second session. Now, the polyp was adenomatous. Yes, you got to bring the patient back on a time scale that ranges from 1 year, 3 years, or 5 years. So again, I'm not going to go into the details of that, but it can be 1, 3, or 5 years, depending on the adenoma. If the colonoscopy was clean, either never again or every 10 years. If there are high risk factors, the patient has multiple family members having colorectal cancer, bring them back at least every 5.
Anatomically, what is the risk of having tumors or polyps and malignancy in the small intestine, and why is it different?
Say that again, Dr. Anand, I couldn't hear you.
Small intestine.
Okay. Thank you, Dr. Manikrishnan. Small intestine is a different organ completely. As you know, it's an absorptive organ. Colon is a waste storage organ, which is mainly concerned with water absorption and excretion, whereas small intestine is an actively, nutritionally active organ. It's a digestive organ. So in fact, large intestine is really not a digestive organ, if you want to be purist. So all of these cancers, I'd say 99% of the cancers that we see as doctors, or as gastroenterologists, belong to that segment. That's colon and rectum. Rectum is the last part, last 15 centimeters or 20 centimeters of the large intestine. Small intestine cancer is very, very, very rare. Okay, we do see some lymphomas once in a while, especially in people with inflammatory bowel disease. But adenocarcinomas are so rare. They're like brain tumors. They're very rare. We do see them, but they're very rare. So there's no need to screen, if that's what you're asking.
Thank you. If there are any other audience questions, we can put them forward. We are at 9 o'clock. If there are no more questions, we can probably think about winding up. Just another screening question. So I think screening mammograms is another area similar to colonoscopy, which is more aggressively and established in the Western nations, which is being followed, and probably not so much. I know it's not beyond the scope of this talk because we are on cancer and we are on screening. Can you comment on mammogram screening for breast cancer?
Yeah, I'll comment on mammograms. It's good you asked. Remember, mammogram does not prevent cancer. It's for early detection of cancer. It is not like, say, colon cancer screening. Colon cancer screening is you look for something that could grow into cancer in 10 or 15 years. So you're preventing cancer before it happens and eliminating it. Mammogram is, the advantage of mammogram is that, if it picks up a small lesion, you could pick it up at a stage where it's completely curable or at a more favorable prognosis. So that is the advantage of mammogram. The true screening actually comes from pap smear, which I said at the beginning of my talk. Pap smear, for people who are not familiar with it, if there are non-doctors in the audience, is basically looking for abnormal cells on the cervix, which is at the bottom end of the uterus, just above the vagina. And if abnormal cells are there, they're not cancer, but these are cells that may, if left alone, grow into cancer many years later. So if you find these abnormal cells, you can do something to prevent cancer in the long run. So that is a classic preventive strategy for cervical cancer. So back to mammogram, well, it's early detection.
One final question. There is a lot of probably also industry-driven genetic screening which is happening. There are panels being sent, picking up markers or sequences which might help predict the incidence of cancer in particular individuals. As far as colon cancer is concerned, is there anything that you are seeing in the rise which might be helpful in terms of genetic screening?
Yeah. We are in many years, perhaps in several decades' time, we will be in the era of personalized medicine. I know it's already been discussed and talked about. Personalized medicine is, you walk into your doctor's office, real or virtual, and they run your genetic makeup and they predict your risk. The question is, do you want to know? That's one question. Second, if they tell you that you could get some sort of an incurable disease or difficult to cure disease, do you really want to know that information? And thirdly, what is the ethics of it? What is the ethic? If you can't offer a cure, what's the point in telling the patient about a death sentence prior? So those are ethical questions that come up. And then how's the privacy of that information guarded? All right. So now we are in a digital era. Anyone can steal information from there. So who do you share that information with? Is your life partner eligible to share that information? So those are ethical questions that come with it. That's a whole Pandora's box out there. But to answer your question, in current day practice, the role of genetic markers or genetic screening is if a particular person has a tumor, a colon cancer, there are some cancers that respond very well to immunotherapy. Now, immunotherapy is basically antibodies that are directed against certain parts of certain molecules within the cell. You might have read about that miraculous trial that was published in the New England Journal just a few months ago on a rare type of rectal cancer that had certain mutations, which was cured by just giving some antibodies. Now, that's a small series, but those are landmark trials. So we are making headway on immunotherapy. And from that standpoint, yes, genetic markers, even for, say, breast, they do prognosticate. And for colon cancer, they not only prognosticate, they also help with tailoring immunotherapy for treatments as adjuncts to treatment. The mainstay of chemotherapy is still good old 5-FU and the usual leucovorin and oxaliplatin. The monoclonal antibodies are also already being used, expensive, I tell you, which is again why in Malayalam there's a saying, "Suji kondu edukkundadu, thumbu kondu edukkunda variya." That's a beautiful statement. That's, I've not seen, stitch in time saves 9 is the English equivalent of that. If you can screen this person, at least with an FOB test, you're doing the patient a service. And an FOB test comes back positive, send the patient for at least a sigmoidoscopy, and you've done your bit. Ideally, a screening colonoscopy at a place where the patient will come back and thank you for the experience. So you want to also grant the patient a good experience. So that also matters because you're sending a well patient for a procedure. So it must be done so safely that the patient should not have a problem, if you know what I mean. Just like vaccination. Vaccination is being done for the healthy population. So you can't afford to have a problem with vaccination. So likewise, screening must be done in settings where it is confirmed to be of high quality and safe and comfortable.
Thank you, Dr. Rajeev, for
Can
that.
can I ask
Yes,
one question?
yes.
Dr. Thomas
Please.
Status here.
Yeah.
Dr. Jayadevan, what is the role? Two questions. What is FOB number one, and what is the role of capsule endoscopy?
Okay, good questions, Dr. Thomas Status. FOB is fecal occult blood, basically stool sample being tested for the presence of occult blood, which you can't see with the naked eye. Using the reagent, it turns into a Prussian blue color. I'm sure we've all done this after doing rectal examination on patients. That's fecal occult blood testing. It can be directed by patient or be sent to the lab. The capsule endoscopy is a different test altogether, where the patient swallows a light bulb-like, small torch bulb-like device through the mouth, and this device takes pictures as it travels through the intestinal tract. It is good for visualization of parts of the intestine that are inaccessible for conventional endoscopy. For example, the small intestine is only as wide as my index finger. So you can't, the colonoscope that we use really does not really enter much of the small intestine. And a small caliber tube can be nicely seen with a camera, like this light bulb-like capsule endoscope. It's not an endoscope; it's actually a bulb-like thing. So that is good for small intestine. But for the large intestine, it has limitations, because the large intestine is a tube which is about that wide, and when it's not filled with, insufflated with air, it collapses. So you're putting this bulb-like device into this collapsed tube, which is going to miss quite a bit of the surface area of the large intestine. So it's not very good at picking up polyps in the colon, but it is good for detecting things like occult source of bleeding. For example, if you have an AV malformation that's bleeding in the small intestine and your patient is getting anemic, say over a few weeks, yes, it can pick up abnormalities in areas that you can't reach otherwise. Good questions.
Thank you, Dr. Rajeev Jayadevan, for that illustrative talk and a very sharp discussion. In the interest of time, it's 9:10. I think we will wind up the session. Official vote of thanks once again, particularly to Pradeep sir for the initiative. And quick reminder, the AMS Mega Weekend is ongoing, and tomorrow we have a basic radiology workshop which is conducted by IMA AMS Trivandrum at the General Hospital IMA Hall. It is a half-day session starting from 9 up to 2 p.m. Although it's called basic radiology, there is a fair bit of advanced stuff which will be useful for doctors, physicians, postgraduates in medicine, radiology, as well as emergency medicine and so forth. The registration is already complete, but there could be some no-shows, and you're welcome to try and join us tomorrow for that session. Thanks officially to Dr. Rajeev Jayadevan for joining us and for that illuminative talk on Cancer Day. Thanks to Jason sir and Dr. Altaf for supporting us with our AMS initiative. And most importantly, thanks to all those who have joined us today evening to hear this discussion. As you've seen, we are working hard to come up with very valuable topics, which is AMS for the rest of the year. Thank you.